First of all, why are we here? I think that's important. Why this group is here today is ultimately to present issues to the co-chairs, okay, to be considered as priorities. And as you may guess, that's not an easy thing to do because everyone in the room has different ideas, perhaps, on what should be priorities. So we set up a process to do that. And you may recall in the last meeting, we talked about what we've done already, and that is we've held some panel discussions. And from those discussions, we created some themes. And among all 5 of the panel discussions that we had, there's some recurring themes. And again, in your packet, there's a list of those recurring themes. You're going to need those for the exercise today. And then we also talked about the criteria. And there's 5 criteria that all 3 work groups will be considering when they consider those issues. And those criteria are also in the packet, and you will need those criteria today as well. Yeah, you're going to have to work a little bit this morning, all right? It's not going to be real difficult, though. So those items are in your packet. So when you think about the process that we're going to go through, it helps me to think of it in 3 steps. Okay, one would be issues that have been worked on by the researchers. The second step are issues that you may believe need to be considered that were not presented by the researchers. And then step 3 is an electronic survey that you will all have an opportunity to complete after we go through all the discussions on the issues. So we have those 3 steps. Today, we're going to work on the first step, and that's researcher issues. We will also work on researcher issues at the beginning of the next meeting on July 24th, because the researchers have come up with 6 issues. There's only time today to cover 4 of those. Okay, so our goal today is to get through 4 researcher issues. Now, researcher issues, first of all, you need to think about who are the researchers. And we're very fortunate that we've got researchers who have agreed to participate in not only this work group, but also the other 2 work groups as well. And we do have Don Abram and Richard Stock, who you will hear from today, Kathy Rao, who's here today, Bob Stoughton, who is here, but also Dr. Sarah Payton, who is with Public Health in Montgomery County and Wright State, and Jane Dockery from Wright State as well. So you're going to hear from 2 researchers today, but all those researchers are involved with coming up with these researcher issues. Okay? And what we did is we asked the researchers to take a look at the community needs assessment, other information that they are aware of, and the criteria to come up with those issues that they believe should be considered. And we're going to go through those today. Keep in mind that these issues are different from strategies. Strategies are those actionable items that will help address a certain issue. For example, in today's Dayton Daily News, there's an article on the 5 Rivers Health System and how they are moving forward with centering pregnancy. Centering pregnancy is a strategy to help with an issue of birth outcomes. Okay? We are not going to get knee-deep into strategies today. That will happen later on. But it is important to know that strategies exist for certain issues. And you will hear today from the researchers, and you will see on some information that's going to be distributed about strategies for the 4 issues that we're going to talk about today. So what we are going to do is we are going to break into 3 small groups, okay, eventually. And in those groups, we're going to talk about the issues. So the way that this will flow, and if you get confused over my poor description here, don't freak out over it, okay? Once we get rolling in this, it will become very clear to you what we're doing because we're going to repeat it. But with each issue, the researcher is going to provide information and make a presentation for 5 minutes. And then there is what we call an issue sheet that describes the issue, and the issue sheet is anywhere from 2 to 4 pages long. Okay? It's a lot of information, but it will help you in the discussion. So after the 5 minutes, then you will discuss the issue in small groups for no more than 20 minutes. You will use your note-taking form to take notes. Use your information, your knowledge on the issues, and you will use the criteria kind of as a guide for your discussion. You will discuss the issue in the small groups. Please take notes, because you will need those notes at the end of the process when you take the electronic survey. You will need to refer back to those notes. You will not be scoring the issue today in your small groups. You will not be reporting out in the group, so you don't have to think, am I going to be selected to report out in the group? You don't have to worry about that either. So after we get through issue 1, again, a 5-minute presentation, distribution of the sheets for you to use in your discussions. You have the 20-minute discussion. We move on to issue number 2. 5-minute presentation, we repeat the process. We will repeat that 4 times. And I will describe how you can present issues as a participant issue. Remember, that's step 2. And we'll be done. Okay? Then we come back July 24th. On July 24th, we will have a big discussion on the 4 researcher issues that you consider today. We think it's important that you have a large discussion, because when you are in group 1 this morning, subgroup 1, you're not going to be able to hear what people in subgroup 2 and 3 have to say. So in that large discussion in the next group, we're going to have just about a 10-minute large group discussion on each of those 4 topics. Then we will also need to hear about the other 2 researcher issues. And then when we will hear about participant issues in that meeting number 2 on July 24th. So basically then we repeat the process for those participant issues. Okay? So if I've confused you, just hang with me, okay? You'll figure it out as we go through. This morning, when you are in your small groups and you're looking at the criteria and you are comparing the criteria with the issues, there may be a couple items that really doesn't make a whole lot of sense. For example, in the first criteria, which is reoccurring themes, there may be a couple reoccurring themes that you just say, that really doesn't apply to this issue. Just simply say, okay, that doesn't apply, and just move on. Don't get stuck on it. Also, the third issue is with regard to community support. That criteria is to try to gauge how much support is there in the community to address a certain issue. And does the community think that it is a problem? All you need to do is simply discuss what your perception is with regard to community support. Community could be a single individual, it could be certain subpopulations, it could be the entire county, it could be elected officials. It could be whatever sector you want it to be. So if you could please have that discussion in your small groups. In the third meeting then, which is August the 11th, then we will have large group discussions on those new issues we talked about at the second meeting. And we will also talk about any other items that we have not addressed up to that point. Then the third step in the process, remember, is an electronic survey that you will take. That will happen probably late August or early September. So you need to take notes, because you will forget when it comes survey taking time. It will also be important for you to take notes when we have the large group discussions on these issues as well.
All right, so if everybody will take out your issue sheet and look at that. Pretty much I'm presenting to you chronic diseases, and this is a very broad topic. We chose 3 that kind of the highlight. We did heart disease, diabetes, the ones that are most, common, cancer. So what we realized is that half of Americans have at least one of the chronic diseases, and 1 in 3 have maybe multiple chronic diseases. So we definitely feel this is a definite issue for Montgomery County, mostly because it costs money in the form of medical costs and lost productivity. But when we think about why it matters, we can look at, what we can actually quantify are deaths. And so we see in Montgomery County that 6 out of the 10 top causes of death are related to chronic diseases. And this is a definite change from back when people used to die of influenza and those other acute illnesses. Now it's the chronic diseases that they're dying from. And we see it kind of broken down by males and females, by gender. We see definitely males have a few more chronic diseases that they die from. And you see in the white versus black, diabetes is number 3, which is one of those chronic diseases, where it doesn't fall till number 7 for whites. So you definitely see a difference as far as disparities go. So that is something that we can actually quantify in the deaths. We can look at, though, what people have reported that they have, and that's kind of self-reported data, and that is not as accurate as actually looking at deaths. But definitely we see there's an issue with those diseases in Montgomery County. But one thing you can think about when you think about chronic diseases is prevention. And so when you look at the actual causes of chronic disease, they're mostly behavioral, things that can be changed. Tobacco use, obesity, excessive alcohol use, poor nutrition, physical inactivity. So when we think about chronic diseases, we actually think about more prevention. And we think about that's how you kind of deal with chronic diseases. If you look at the chart on the back, you see that I've listed different things that the issues that can be behavior that can be changed. And this is self-reported data. And this kind of puts a health disparity lens on it. You see that for all of these issues, except for obesity. Overweight, 39% Black are considered some overweight compared to 36% of all adults and 35% of white. The big difference is you look at high blood pressure. 45% of Black, 36% of all adults, 34% of white. But you see that there's definitely a disparity when it comes to all those issues. Eating vegetables. And it's kind of sad though, throughout for all Montgomery County, that only 24% have less than one, they have at least one, vegetable a day, and 41% eat the fruits a day. So those numbers are kind of discouraging. When you look at children's health, the data from the Dayton Children's community assessment that they put out, you see the alarming number that are obese and that are overweight, much more obese children than overweight. And you look at how much physical activity, 6 and 10-year-old, 46% get less than 1 hour of physical activity a day. So that's pretty alarming as well. We have one of the criteria is look if there's evidence-based research available, and I've listed a few websites, 2 that I thought were really interesting if you do want to take a look at what community evidence-based research is already out there. The community guide, this is a guide to community prevention services, lists tons of different already evidence-based strategies that are taking place. And one that I kind of like, because that's my area that I am interested in, is like crime prevention through environmental design. That kind of brings in the crime and your chronic diseases issues as well, and looking at how you can change the environment to kind of change if people can exercise and walk and accomplish those things in order to live a healthier lifestyle. And I think we have community health assessments on all the tables. And if you don't have your own copy and there's enough, please go ahead and take one. I don't want to take any back with me, so I didn't get your copy. If you want to look further on the issues, you can look in the different tabs. That's on page 45. You can maybe write these down so you can discuss them. Heart disease is on page 51. And we have diabetes on page 49. And cancer, which I didn't mark, is on page 52. So those are references you can look at as you're talking. 5 minutes.
So issue number 2, again presented by Dawn, is access to food. Dawn?
Okay. This issue is actually one that we're presenting for here and we're presenting for income and stability. So So this one is crossing multiple groups. I'm going to start off, if you first look at the back of your sheet, you see a map. And these are your food deserts. And one thing I want to clarify at the beginning here is that food desert has been a word that's been used and tossed around. And I want to kind of explain to you the definition that I have used and the kind of the common definition. USDA has an original food desert definition. And so a lot of times people say, hey, there's a supermarket down the street, how come this is a food desert? But there's some qualifiers that take place. First is by census tract. The census, the poverty rate is 20% or greater, or the median family income is at or below 80% of Montgomery County's total median family income, and at least 500 people, and 33% live 1 mile from a supermarket or a large grocery store. And that's talking about like a Kroger's or a Myers, not your little mom and pop stores. Or in the rural area, rural census tracts, that's 10 miles. So understanding what a census tract, what a food desert is, kind of frames this a little bit better. And if you look at my numbers, Montgomery County has 153 total census tracts, and 29 of those are food deserts, and that's 19%. The city of Dayton is 59 of those census tracts, and of the 59 census tracts in Dayton, 19 are food deserts. That's 32%. So when we look at our total, 65% of Montgomery County's food deserts are located within the city of Dayton. So the city of Dayton is the area where there's a majority of your food deserts. You can tell that from the map. So why do we care about this? The fact is that people not getting access to healthy foods is one of the, we talk about chronic diseases. One of the reasons they're getting chronic diseases is they're not eating healthy, and that was one of the risk factors. Although that is a behavioral risk factor, we have to kind of show them how to find healthy foods. If they don't have access to healthy foods, that's a hard behavior to change. So that's something about census tracts, food deserts, if you understand the definition. Another thing we have to think about is, if I can get this to change, food insecurity is another aspect of access to food. Now, this is when you may have access to food, but it's inconsistent, and that can be due to a lack of money or other resources. So the fact that, you may live close to someplace, but you cannot get adequate supply of food. Your children may go hungry. You may miss a meal here and there. It's hard to put food on the table every day. And we see here, I wasn't able to add this to your sheet because I have so much stuff on here already. We look at in 2013 comparative rates. Montgomery County is definitely higher in overall food insecurity and child insecurity as well. In those 18-year-olds and younger, 25% of children in Montgomery County are food insecure. So what happens when you're hungry or you're in a food insecure household? Those mothers who are pregnant, they have a chance to have a low birth weight baby. That child is developing poorly. You may be born with mental disabilities, learning difficulties, maybe those first 2 years of life. But you think about those children going to school hungry. They have lower energy levels. They have inability to learn. Academic performance suffers. They have behavior problems. You imagine if you're hungry, finding hyperactivity, aggression, anxiety, mood swings, bullying, not able to focus. They may not attend school at all. And they may have some other chronic childhood diseases like anemia, asthma. And those adults going to work hungry, their productivity level definitely suffers from being hungry. So we see that, according to my graph here, food insecurity is actually on the rise. For the last 2 years, food insecurity has actually increased in the area. So some things that I wanted to kind of draw your attention to, and where I kind of learned more, this is just me, I found a neat source. If you ever want to know the farmers markets that have been, USDA has access to, the USDA Farmers Market Search is a really neat tool to go on to find your farmers markets. It kind of tells what they sell, what kind of form of payment they take. I found that resource, that was pretty neat. And another one, what are your evidence-based practices? The New York City green cards is one of those evidence-based practices that I did find, where they have like food carts, like food vendors. They can truck into a Murrow or whatever, sell food, pack up and go home. You have to might get a license for it. That's one of the evidence-based practices. And they also have, of course, our school meal program and WIC are two other evidence-based practices that we currently have in place that can be referenced as well. In your community health assessment, we have an access to food section that is on page 78. It has some additional information for you.
The issue we have it as alcohol and substance use, and originally the researchers wanted to separate alcohol and substance use primarily because we feel as if alcohol always just sort of gets, yeah, we know it's a problem, but hey, what the heck? But they asked us to go ahead and combine them. I decided that was okay because at the level of prevention, right, when you're talking about prevention and you're thinking about intervention in those early 10 to 15 to 16-year-olds, then you're going in the same direction, which is why it's okay. The other thing that you don't see here very much, you'll notice that when you get the issue handed out, it's entitled Brain Health, Alcohol and Substance Use, and Helen asked us to put that in there for a very appropriate reason, which is in the last 5 years, it's becoming very, very apparent, right? You can take pictures, you can see the way in which the brain both differentiates, right? There are differentials beforehand, and then you start to see real differences in the hardwiring of the brain associated with both substance use and alcohol, and she thought that was an extremely important thing for us to emphasize. All right, so what do we know? Well, long term, we know that we've had this alcohol problem for a long time. And if you do the numbers, you got 48% of the people who drink, right, and about 20% that do binge on alcohol, at least in the last month. But the real problematic thing, of course, for us is that in those critical 18 to 25-year-olds, binge alcohol use is at around 39%. It's just about double what it is for adults later on, and all kinds of things start happening in those critical years. With respect to substance use, you know, there's this sort of separation that occurs between marijuana and other, illegal drugs, but a lot of people would tell you that it's a mistake to do that type of differentiation precisely because of the gateway nature of alcohol, of marijuana. And so you'll see the numbers there, but if you want to ignore that, then you can essentially go somewhere between 3 to 4 out of every 100 are using illegal drugs over this last month. Our data at that sub-state level has a lot of error ranges around it. It comes from the National Survey on Drug Use and Health from that 3-year period, 2010 to 2012, and the error ranges for the sub-state area that is Montgomery County are relatively large. Because it's that 2010 to 2012 period, it does a sort of a separate division for cocaine, but it does not break out the opioids. But as all of us are aware, opioid and heroin use has exploded locally, and the way in which we capture that here to talk about it is to look at the huge increase in the number of people seeking treatment for opioids, and you've got that enormous increase that you see quoted under the issue with respect to that, where, in fiscal year 2009, you were at 1,800 seeking treatment for opioid disorders, and you're up to 2,700 in fiscal year 2014. And if you looked at fiscal year 2015, year to date, that number would even increase more. And we also know with respect to the poison deaths, and you got that differential just where you see heroin. This isn't all opioids when you're looking at that quote down there. It's just the heroin that's in the system, and that goes from 39 in 2010 to 127 in 2014. Why does it matter? Well, there is this huge literature that talks about all the effects that both alcohol and drug use had. So, I listed those, and there's a part of me that feels guilty because I did this nerdy academic thing on the second page, just because there is so much there and you sort of need to emphasize it. What I want to say about that literature, though, is there is this extremely strong connection to poverty, and the connection works both ways. You know, being poor is a causal factor in alcohol and drug use. And we know that now, right? Because the models are getting much, much better, right? We've got all these advanced quantitative analysis out there that's able to differentiate longitudinally, right? And so we know it's not just, oh, because you're a drug user, you wind up being poor. It's because you're poor, you also wind up being a drug user. Same way with respect to alcohol. So that intimate connection to poverty sits there with poverty as a causal factor. But we also know all the types of things that alcohol and substance abuse start to do with respect to children even before pregnancy. The county has had a focus for a long time on the fetal alcohol syndrome stuff, but it's also the case that there's a literature out there now that starts to document the relationship between substance use and prenatal health. Relationships to jobs, relationships to HIV and AIDS, and relationships to property crime are straightforward, particularly with respect to the opioid use. Those relationships are extremely strong. And in the areas where you're seeing that rapid incidence in East Dayton and in Northwest Dayton, then there's lots of evidence for that. Dawn put together some great maps for us based on zip code data that we had. And we're doing that. We've done this with respect to the Adams client rates. Just as an example, they're at the zip code level, and you can sort of see the client rate per thousand, and you can start to see where the hearts of the opioid related disorder epidemics and the alcohol related disorder lies. There are problems with these zip code maps, and we have some more detailed data if anybody is interested, where we've looked at the emergency room and inpatient rates on alcohol and drugs, and we'd be happy to get that for you. What we are talking about here is we wanted to emphasize depression and anxiety as sort of extremely important sub-elements of mental health disorders relative to some that you might have considered more chronic. They're tied to lots of things that we can do something about. Someone brought up something that I think is important. We are showing unique counts for Adamus clients, and it is the case that there is some private insurance behind both substance use and mental health, and so our data is a little bit distorted because we are looking at Adamus-related claims, which are both human service levy and Medicaid claims, and so there are some distortions there, but it's the best data that we have. Separate from that, so we have those sources of data on the way what's happening with incidents, and so you see increases in treatment for depression, for various of the childhood things, because all childhood things essentially, no matter what they are, get called attention deficit disruptive behavior disorders. And then you'll see the darker blue line is the increase in anxiety. So you see both the anxiety and depression. And once again, I want to emphasize the brain health things, and we'll talk about those in a minute. Separate from all that is that, once again, NSDA does have prevalence data down at that sub-state level. And so when you're looking at that incidence of mental illness in Montgomery County, the way in which they talk about it is they talk about major depressive episodes, and they talk about serious mental illness. So 8 of 100 residents had a major depressive episode in the last year. Whether that's 6 out of every 100 or whether that's 10 out of every 100, the error ranges are pretty dramatic. But the incidence is relatively common over our 3 main illness groups. Serious mental illness, just fewer than 1 in 20, or around 4.6% are estimated to have had a serious mental illness in the past year. Notice what that means. That means almost no one in the room is not familiar with someone, either a close friend or a relative, who has been suffering from a serious mental illness, just in terms of those degrees of separation. Why it matters. There is good evidence that job loss leads to an increase in major depressive episodes. one of the sick little things about the Great Recession is it gave us an opportunity to see which way causality went, right? You know, it was sort of like, well, do people just become unemployed because they're depressed, or does unemployment lead to depression? So we had this nice natural experiment. And so now we know it is this one-for-one thing. Unemployment does, in fact, lead to greater incidence of depression, and the effect is linear. That is, you know, as unemployment goes from 5% to 6%, the increase in depression is by a certain amount, the same increase for every 1% increase in unemployment, okay? And once again, there is this relationship to poverty and childhood poverty, and lots of documentation about the relationship between poverty and mental illness. The bottom line, you know, is, you know, on those reviews, there was this huge study that looked at childhood socioeconomic status and adult mental health disorders, and across 20 of the DSM-4 mental health disorders, childhood financial hardship, predicted onset of all classes of disorder at every life course stage with odd ratios of 1.7 to 2.3, meaning you were twice as likely if you were born poor to sort of suffer from those things in adulthood. And then there's an evidence base for it. And you see the depressive disorder elements for Adamus, right, over that 5-year period. Again, those sort of warnings about the distortions caused by not having sort of the private insurance mix. But on the other hand, you also then, I pulled the GDAHA, gave us the emergency room and inpatient data. We have lots of maps if you want more maps, but I just went ahead and pulled the mental disorder diagnosis for the 20 to 64s, and you can see that, you know, you still see that higher incidence, of course, tied to poverty. Which is not to say, and Bob Gruhl was talking about this, which is not to say that these are not serious illnesses and disorders, both all the substance use and the mental health disorders at higher income levels as well. And then there is that recent research. They just did this other study talking about the relationship, you know, to the brain, right, where there is this 30% increase in brain inflammation, right, associated with someone being depressed, and they can, you know, now show you the pictures, right, if you still want to pretend that it's all in your mind. That's absolutely correct, but your mind has a physical basis to it.
So what do you
We have 3 different types of data, and I've just done 2 of them here, sorry. So one type of data we have is from the National Survey on Drug Use and Health. And that's prevalence data by this very detailed national survey. And they use the 3 years of data. And so that's evidence of prevalence. When we're down looking at the level 3 diagnostic categories, both with respect to the substance use disorders and the mental health disorders, we're using Adamus data on claims and looking at unique client counts for people coming into treatment for either substance use disorders or mental health disorders. That data is slightly distorted. It's more distorted than it used to be. There was no private insurance for many of these things, and so that was really a pretty good estimate. Now there is, and so we are, anything you see here is an underestimate of the full magnitude because of that in terms of people seeking treatment. So there's that data. The third source of data, which is actually sort of pretty good in terms of thinking about, if you're trying to think about where problems lie at a county level, is we have data from GDAHA that comes out of, I've forgotten, it's some decision software that all the hospitals use at the state level, and it reports 2 different types of data. One is emergency room treat and release counts, and you can get that down to very detailed ICD-9 diagnostic categories. And so for those, and then also inpatient counts by those ICD-9 diagnostic categories. And for those, then, we are polling either all, for example, alcohol-related disorders, and there's a set of those that are defined, and or mental health disorders. There's a large category for mental health disorders as those get defined. So that's the other type of data that we have. That data is probably, if you were trying to look at geographic spread,
that data in some ways is some of our best data because you'll have people coming in from all over the county, whatever the basis is for their insurance.
First of all, thank you very, very much for working on those 4 issues. Keep in mind, at the next meeting, we'll have a large group discussion for about 10 minutes on each of those 4. Then we will also work on the remaining 2 researcher issues, which is birth outcomes and violence. Okay. And then we will also discuss any participant issues. You are the participants here. The participant issues, so that's the second step in the process. Again, the first step's researcher issues, then participant issues, and then the survey. So participant issues would be an issue that any of you believe should be considered by the co-chairs as a priority that the researchers either didn't present today or will not be presenting at the next meeting. So to submit an issue that you believe should be considered, you basically need to do something similar to what the researchers did. You need to provide a narrative, taking a look at the criteria, and explain why you believe that it is a significant issue. You need to link or cite supporting data or research. And at the last meeting, we had a nice offer by the researchers that they said that they would be willing to help if you need some help with regard to the research. So you would need to let us know that as well. And try to do this, we were going to say in two pages, but since Richard used 4 pages, including maps, then I guess you need to have at least 4 pages. But the more condensed, the better. And what's going to happen is that the researchers are going to review that information, get together with the facilitator and more importantly the co-chairs, and decide whether or not that the issue should go forward. Obviously, if we get 50 issues from you, then that's a major problem that we have. Okay, so the issue that you bring forward is going to be reviewed by the researchers, okay, and discussed with the co-chairs to determine, where it goes from there. We need those issues by July 15th. Because think about it, we need to talk about those issues on the 24th. So they need to come in on the 15th. We need to do our review with regard to the researchers and the co-chairs, and then to be able to respond in a very quick manner. And there is a location where you would submit those, and it's with regard to the county site with hspd@mcohio.org. This slide that I'm referring to is in your packet. Okay? So it's all there for you. Okay? The last item I wanted to mention is that later this week, we will send out an email to you and to all of the other work group members who are not here today. And then there's going to be a lot of information. It's going to include the video link of people who were talking up front here today, not of your discussions. We didn't have microphones underneath the tables or anything. So that sort of video. And also it's going to have the issue papers attached as well. And then there will probably be some other information there. So look for that. I think our thinking right now is that we are going to send the email out, not only to this work group, but the other 2 work groups as well, so the other 2 work groups know what's going on, and then you would be also receiving the email from the other 2 work groups. Does that make sense? There's no use hiding all this. You can have it all, so you can see what the other work groups are also talking about.